trick that you can do is take the plastic packaging off of a Kerlix wrap, and some of them are small, pretty small, but if you just have a small loop of bowel, which is the typical abdominal evisceration, you can just lay this piece of plastic over that and tape it down, and now you've basically turned this thing into kind of a colostomy bag. It's gonna remain moist. That loop of bowel is gonna not get hypothermic, you know, and so you're gonna keep it warm, moist, and protected. And then if you want, you can lay a very loose dressing over this. But that's just a kind of a good little trick on how to deal with a small part of a bowel or a loop of bowel that's eviscerated out of the abdomen. Another thing that we're going to look for is eye injuries. If this patient has a significant eye injury that we need to bandage, one of the big things that really contributes to a poor outcome with the eye is increased ocular pressure when there's an eye injury. So if we can prevent that from happening, prevent pressure on the eye, we can really help that eye have a successful outcome. So we do carry the small eye gauze eye pad that we can lay over, but you know, we all learn to find a cup or something to place over to protect the eye. Those are hard to find on scenes typically, so that's why we carry the eye protection in the trauma kit. Something you can do is if you have some bleeding or an eye that's come out of the socket, you can just place the eye pad over that very loosely, and then you can place the eye protection glasses on. And there's about an inch of clearance between the eye that is in the socket and the glass, so you're going to protect that eye from getting pressure on it. Once you've done that, it's over both eyes. What you can do is use some ACE wrap or Kerlix, and you can wrap over the eyes or the glasses. Obviously, you don't want to cover the nose, but you can just wrap these glasses in place. That way, the patient's not looking around, and you're preventing any further injury from happening. As you can see, I'm really not even making this ACE wrap tight, and it's staying really well on the head. On a person, not a mannequin that's rubber, but on a person, this is even going to stay in place better than on here. So you can see it's a lot more effective than the Kerlix. And then you've got the Velcro closure that we can put in place and cover that. We already talked about how to use that burn face mask. You can pour some saline in there and then place it. Some of the kits have a burn sheet in there in place of the second trauma dressing. I don't think that's a bad idea. But really the burn sheet in a burn patient, our initial on-scene management really should be to obviously stop the burning and then get the clothes removed. And then typically we lay that burn sheet on the gurney and then place the patient on there. So that's kind of more leading to the transport phase, that we have that burn sheet on the gurney and place our patient on there and then wrap them up in it. So that's why you might not find one in the trauma kit, and you might have to get it from the ambulance once it's arrived. One other thing that I want to talk about is the other type of tourniquet that we have in our triage bag is this ratchet tourniquet. And really, it's most effective, it seems like, on larger patients and on the lower extremity, but it can be used on an upper extremity. We have one of these in the triage bag, as well as two of the CAT tourniquets in there. So this has a small buckle here that you can see, and it's a lot easier if you can just slide it up rather than removing it and going through the buckle. But then it has this pull tab here, so you just, on the strap it says 1 pull, and then this is some just backward pressure. Remove all that slack out of there, just like in the CAT tourniquet. And then the next thing we're going to do is we have this ratchet here with a number 2 down there. And so once we've removed all the slack out of this tourniquet, then we can just lift this ratchet, and it's gonna, that's how we're gonna get our pressure. It doesn't, from studies I've read, it does not provide quite as good of circumferential pressure as the CAT tourniquet or some of the other tourniquets on the market. But I think it is still effective. One of the other downsides of this is this orange button here is how you remove this tourniquet, so it can inadvertently be pressed, and that just blows out the tourniquet, and now you've lost all of your pressure. So I think the CAT tourniquet is a little more aggressive and a little more effective at staying in place. So that concludes the training that we have on these trauma kits. Obviously, open it up, spend some time before you actually need this equipment in a high-stress situation to get to know the changes that we have and look in. We have several training kits that are set up so that you can actually get some hands-on skills, and good luck.
So try and get direct pressure on it, kind of get eyes on it, scoop out any excess fluid. Just keep on doing this until it's full. Keeping pressure on that point.
That's gotta hurt.
Okay, and once you get the cavity full, you can even use whatever's left in here. Make it a little bigger. And here, 3 minutes direct pressure.
Okay.
No peeking.
No peeking. And if you're using the quick clot stuff, you can use this as a thermal barrier.
So this is the management of penetrating chest trauma. We're simulating skin with this Chuck's pad, and then underneath we have a rib cage that has a 9mm gunshot wound that has gone through the bone. There's a large wound cavity there that's going to be a lot bigger than the entrance wound. Got bone and bullet fragments, and then a large exit wound that has quite a bit of bullet fragmentation, and there'd be a lot of it within the chest cavity. All that bone went somewhere. So the first thing that we're going to do to manage this is start with just a gloved hand to cover that wound, and then we can use a chest seal. Expired defib pad placed directly over the wound. This can be burped to relieve a tension pneumothorax, or we can decompress the chest. So with chest decompression, we've got a couple different size needles. This is the regular angiocath. It's about a 2-inch needle, 14 gauge. This is the Cook needle that's a little bit longer. And then this is the ARS needle that's 3 1/4 inches. They're all 14 gauge. So to get a positive response that you're in the pleural space, you can take a syringe with sterile water, sterile saline, and just draw up a small amount, and then place that on your needle. And then starting from the head being up here, we're going to go mid-clavicular line to the second intercostal space, counting down, so directly over the third rib. And we're going to just want to ride over that rib. So right now, because there's negative pressure in the syringe with the stopper, the saline's not going to flow out. It's good to put some tension on the skin, and then just make a small incision into the skin with the needle. That'll help to allow the catheter to advance and kind of decrease the resistance. So we're going to go over the rib. Once we're in the chest wall but haven't passed into the pleural space yet, we can remove the stopper on the syringe, and then we're going to continue to advance the needle. You'll find a decrease in resistance and know that you're in the pleural space. Don't advance the needle anymore. What you may have is some bubbles coming up through the fluid, which would indicate that you relieve some of the pressure, but oftentimes there will be a large or a small tissue or some sort of a little plug inside the needle, so we're going to want to clear that. So we're just going to bump it. So put the syringe or the stopper back into the syringe and push that through, and that's going to force that the plug out of there. And then you may get some bubbling that comes up. Remove the needle and then advance the catheter until you meet any resistance. You can stop there. The catheter doesn't have to go all the way into the hub, and then you can just leave it there to indicate that you decompress the chest. If the patient starts to develop a tension pneumo later on, what you can do is take a syringe and get a little saline in there again and attach it and see if it's developed like a blood clot inside the catheter, and you can force that out again and then see if that relieves. Otherwise, you might have to repeat the chest decompression or burp the seal.